You know, if you break a bone, an X-ray gives you this really clean, satisfying answer, right?
Oh, absolutely. It's very binary.
Yeah, you look at the film, you see the jagged white line, and it's either broken or it's not. I mean, it's basically just structural engineering.
Right, but when you step into the world of clinical human nutrition, that X-ray machine is completely inadequate.
Totally useless. Because we're suddenly navigating a landscape that isn't just about bones and tissues.
No, we're looking at the microscopic chemical reactions that, sustain life and dictate recovery.
And literally physically construct future generations. So welcome, everyone. Today, we are taking a deep dive into the foundational science and clinical application of dietetics.
Specifically pulling from Williams's Essentials of Nutrition and Diet Therapy, the 11th edition.
Right. And if you are a medical student prepping for rounds, maybe a young professional entering the clinical field, or, just a self-taught learner who wants to understand the exact biochemical mechanisms keeping you alive, you are in the right place.
Because we are moving way past that generic advice about, just eating well.
Exactly. We are looking at nutrition as a precise medical intervention capable of doing everything from treating life-threatening acute illnesses in the ICU to literally reversing the physical decline of aging in a 90-year-old.
It really is a massive paradigm shift once you get into those clinical realities.
For sure. Because nutrition science, it's the critical bridge between biochemistry, human physiology, and behavioral science.
And we often take it for granted, right? But the food a patient consumes isn't just fuel.
Right.
It's the raw metabolic material required for literally every single cellular process.
So let's start right there at the cellular level with the biochemistry of nourishment. We all know the basic macronutrients.
The carbs, fats, and proteins.
Right. And anyone who has ever looked at a nutrition label knows the basic fuel factors. Carbohydrates and proteins provide 4 kilocalories of energy per gram,
while fat provides a highly dense 9 kilocalories per gram.
But in a clinical setting, that density difference isn't just, trivia for a high school health class.
No, not at all. It dictates exactly how we manage a patient.
Like how so? Give me an example.
Well, say you have a patient in respiratory distress or someone requiring total parenteral nutrition.
That's the IV drip providing all their nutritional needs.
Exactly. You have to calculate those exact fuel factors to formulate a lipid emulsion that delivers enough energy without overloading their system with excess fluid.
Wow, okay. So the density of fat becomes this life-saving clinical tool.
It really does.
So the macronutrients are the heavy lifters, right? The bulk energy. But then we have the micronutrients, the vitamins and minerals.
Yes, the essential microscopic pieces.
And there is this fundamental biochemical dividing line between the two that I think gets completely lost in the public conversation.
Oh, for sure. People lump them together all the time.
Right. But vitamins are incredibly complex, fragile organic molecules. Their main job is to act as coenzymes in cell metabolism.
Whereas minerals, on the other hand, are simple inorganic elemental structures.
They act as metabolic cofactors, but they're also physical building blocks, like, calcium in the skeletal system.
Exactly.
So thinking about this clinically, are vitamins basically like the fragile software code of the body that can easily corrupt under stress?
I like that analogy.
And then minerals are like the indestructible hardware, nuts and bolts.
That is exactly how you should conceptualize it. Think about the physical properties.
Okay.
Vitamins are organic, meaning they contain carbon, and they are highly susceptible to being destroyed by heat, light, or oxidation.
So if you boil certain vegetables to death,
you are essentially corrupting the software code. The vitamin degrades and completely loses its chemical function.
Wow. But minerals don't do that.
No, minerals are fundamental elements on the periodic table.
Yeah.
You cannot destroy iron or calcium by boiling it.
Right, it's indestructible hardware.
Exactly.
But wait, that raises a massive biological contradiction to me. Well, if minerals are just basic, indestructible elements found everywhere in soil and rocks, shouldn't it be incredibly easy for our bodies to get them?
You would think so, yeah.
Why do we see massive mineral deficiencies worldwide, even in places with access to whole foods? If the hardware is indestructible, why are we constantly running low?
Because presence does not equal availability.
Okay.
This introduces one of the most critical concepts in clinical nutrition, which is bioavailability.
Meaning what exactly?
Meaning it's not just about what is on the plate or even what you swallow, it's about what your body can successfully extract during digestion.
Oh, and then transport across the mucosal barrier or the intestine into the bloodstream.
Precisely. The amount of a mineral found in like a laboratory analysis of a food is often vastly different from the amount the human body can actually utilize.
Because something is blocking the absorption.
Exactly. We have to account for interfering binding substances that are naturally present in the food itself.
Okay, give me an example of that.
Well, spinach is a classic one. It's famously packed with calcium, right?
Yeah, Popeye's favorite.
Right. But spinach also contains really high levels of oxalic acid.
And what does that do?
In the gastrointestinal tract, the oxalic acid physically binds to the calcium ions, creating an insoluble salt called calcium oxalate.
Oh, wow. And the body can't break that down?
Nope, your body cannot absorb that bound structure.
So the calcium is there. The hardware is physically in the warehouse, so to speak.
Yes, but because of that binding agent, it gets loaded right onto the outbound trucks and passes through your digestive tract.
Without ever getting installed on the factory floor.
Exactly.
That is fascinating. So the biochemistry isn't just about the nutrient itself. It's about the entire chemical environment of the gut.
Absolutely.
And that baseline biochemistry gets even more complicated when we start looking at how a patient's physical requirements change over time.
Right, moving into the life continuum.
Exactly. We start at gestation. And the source material highlights this profound concept. A pregnant mother isn't just transferring calories to a fetus.
No, she is establishing a multi-generational nutritional heritage.
Right. The biological building blocks she consumes are physically constructing the metabolic and epigenetic foundation of the next generation.
And what's wild is that biological foundation rapidly merges with psychological development.
Yeah, let's talk about that. When we look at early childhood, we have to look way beyond mere calorie transfer.
The book brings in psychoanalyst Erik Erikson here.
Right, Erickson's theories.
He theorized that the physical act of feeding an infant is the very foundation of psychosocial development.
So an infant's neurobiology is literally wiring itself based on those feeding interactions.
Exactly. It is the fundamental mechanism through which a human being learns to trust their environment and their caregivers.
So the clinical takeaway for you listening is that the physical and the psychological are entirely inseparable from day one.
You aren't just feeding a stomach.
Right. You are building a central nervous system's capacity for trust.
It's incredible.
It is. But let's fast forward past all that development and get into decline. As we transition into middle adulthood and older age, the biological reality shifts, right?
Oh, dramatically. Hormones change. Growth hormone drops.
Testosterone drops.
Yeah.
Cellular replication just naturally slows down.
And that's when we face the reality of sarcopenia.
Which is the severe age-related loss of muscle mass and function.
It is a devastating public health issue. Honestly, by the time someone reaches their 70s, their muscle mass can easily be half of what it was at age 30.
Half. That's insane.
Yeah, and this leads directly to frailty, to falls, loss of independence, and just astronomical healthcare costs.
But there is this phenomenal study mentioned from the Human Nutrition Research Center on Aging at Tufts University.
Oh, I love this study.
It completely flips our understanding of what is biologically possible. They took frail, nonagenarian nursing home residents.
We are talking about people 90 years old and older.
Right. People who needed assistance just to stand up out of a chair.
Yeah.
They put them on an 8-week intervention of progressive resistance training paired with a targeted protein intake. I think it was 1.0 to 1.5 grams per kilogram of body weight.
That's right.
And in just 8 weeks, these 90-year-olds dramatically increased their muscle mass. They regained the ability to walk unassisted.
It's almost unbelievable.
Well, yeah. Here is where it gets really interesting for me. Wait. If the text says cellular replication naturally slows down in middle age and growth hormones drop, how is it biologically possible for a frail 90-year-old to synthesize new muscle tissue that rapidly?
Right. It feels like it shouldn't work.
Yeah, I thought the factory was effectively shut down.
If we connect this to the bigger picture, here's where the biology defies our everyday assumptions.
Okay, explain it to me.
To understand the how, you have to look at cellular signaling pathways. Specifically, a protein complex called mTOR, which acts as the master regulator of cell growth.
Okay, mTOR.
Yes, the systemic hormones like testosterone have flatlined in these older patients, but the mechanical tension of lifting a weight acts as a powerful, localized stress signal to the muscle fiber itself.
Just the physical tension alone.
Yes. And when you immediately pair that mechanical stress with an amino acid-rich meal, specifically the amino acid leucine, it powerfully activates that mTOR pathway.
Oh, wow. So it acts as like a localized override switch.
Precisely. That combination of mechanical tension and targeted amino acids effectively bypasses the need for the systemic hormones.
That is wild.
It forces the muscle to undergo protein synthesis to almost the exact same extent as it does in much younger individuals.
So as long as you provide the blueprint, meaning the exercise and the exact chemical building blocks, the muscle has no choice but to adapt.
Exactly. The hardware can always be upgraded.
That ability to upgrade the hardware even at age 90 is incredible. But it raises a massive practical issue for you out there on the clinical floor.
Right, application.
Yeah. If a frail 90-year-old patient is sitting in a hospital gown in front of you, how do you actually figure out what fuel they need? You can't just guess or throw protein at them blindly.
No, absolutely not.
We need a standardized clinical method to assess and treat them.
Which is why the clinical floor relies on the nutrition care process, or the NCP.
The NCP, right?
It is a systematic, standardized framework to ensure we are practicing evidence-based medicine, not guesswork.
And it operates in 4 distinct cyclical steps, right? Assessment, diagnosis, intervention, and monitoring.
Correct.
And we really need to draw a sharp distinction in that second step, the diagnosis.
Yes, this is crucial.
Because in a hospital, we are used to the medical diagnosis. A patient has type 2 diabetes, or coronary heart disease, or sarcopenia.
Right, and that is a static, pathologic disease state.
It does not change as long as the condition exists. But a nutrition diagnosis is entirely different.
It is entirely dynamic. A medical diagnosis identifies the disease. A nutrition diagnosis identifies the specific food or environmental problem that a nutrition professional can treat independently.
Give me an example to separate the two.
Okay, so the medical diagnosis might be type 2 diabetes, but the nutrition diagnosis is excessive carbohydrate intake, or maybe inconsistent timing of meals.
Ah, right.
Crucially, as the patient's habits change, the nutrition diagnosis changes, even while the medical diagnosis remains exactly the same.
Right. You are treating the nutritional root cause to manage the medical pathology.
Exactly.
But so what does this all mean in practice? To formulate an accurate nutrition diagnosis, you have to nail the first step, the assessment.
Yes, you need pristine data on what the patient is actually eating.
And the tools we use to get that data present a fascinating psychological dilemma. Let's look at the 2 most common tools, the 24-hour food recall and the food diary.
Okay.
The 24-hour recall is fast. A clinician sits down and asks the patient to list everything they ate or drank over the last day.
Right. The burden on the patient is incredibly low, but you are relying entirely on human memory.
Which is notoriously flawed.
Oh, absolutely. Patients forget the handful of almonds they ate in the car, or they wildly misjudge the portion size of the pasta they had for dinner.
Exactly. So then you look at the other option, the food diary,
Right.
where the patient records the exact identity and amount of all foods consumed over a period of 3 to 7 days, right at the time they eat it.
Which yields highly detailed data.
Yeah, but it requires serious literacy, time, and cooperation. It's almost like evaluating a patient's diet is like a detective solving a case.
Oh, that's a great way to put it.
Right. The 24-hour recall is like eyewitness testimony. It's quick, but notoriously unreliable because the brain invents details. While a food diary is like installing a security camera, which give you perfect data, but makes the suspect change their behavior because they know they're being watched.
This raises an important question about human psychology. It's a classic example of the Hawthorne effect.
The Hawthorne effect, right, where the very act of observation alters the outcome.
Exactly. The moment a patient has to actually write down that they are eating a 3rd slice of pizza, they often just choose not to eat it.
So they hand you a food diary that looks perfectly healthy.
But it is entirely performative. It doesn't reflect their actual baseline lifestyle at all.
So how does a practitioner deal with that?
A skilled clinician has to navigate this psychological minefield to get the truth. We use cross-referencing, biological markers, and most importantly, we build a non-judgmental rapport.
So the patient actually feels comfortable sharing the reality of their diet.
Right, not just the version they think we want to see.
Which brings us perfectly to the final and arguably most difficult piece of the puzzle, public health and the psychology of change.
Yes.
Because, I mean, you can act as the perfect clinical detective. You can gather flawless assessment data, write a brilliant nutrition diagnosis, and design a biochemically perfect diet plan. But all of that clinical expertise is completely useless if the patient or the community lacks the psychological motivation or the economic resources to actually execute the plan.
Which is what we call the ecology of malnutrition.
Ecology of malnutrition. Break that down for us.
Well, a biological intervention doesn't exist in a vacuum. It exists in a socio-economic environment. Economic stress directly dictates nutritional status.
So you can't just hand out advice ignoring reality.
Exactly. You cannot confidently prescribe a diet centered around fresh Atlantic salmon and organic leafy greens to a single mother working 2 minimum wage jobs who is struggling to pay rent.
Right. The clinical plan is dead on arrival.
It is completely useless.
And that is exactly why public health interventions like the WIC program, the Special Supplemental Nutrition Program for Women, Infants, and Children, or federally funded school meal programs are so critical.
They aren't just handouts.
No, they are the required economic infrastructure that makes clinical advice physically possible to follow.
But even when the financial resources are secured, the clinician still has to navigate the psychological friction. Behavioral change is incredibly difficult.
So how do they map that out?
Public health relies heavily on the stages of change behavioral model to understand why patients get stuck.
Right, I've seen this. It maps out 5 distinct stages: pre-contemplation, contemplation, preparation, action, and maintenance.
Yes.
Let's walk through an example of this from the source material because I think it really highlights where the friction happens.
Okay, let's do it.
Take the public health push to increase folate intake in women of childbearing age to prevent neural tube defects in pregnancies.
A classic public health initiative.
Right. So in the pre-contemplation stage, the patient denies or doesn't even know there is a problem. They might just see a public service announcement on a bus and ignore it.
Right. Then in contemplation, they recognize the problem. They might pick up a leaflet at their clinic.
But this is where people get stuck, right?
Oh, constantly. They get stuck in contemplation because changing a habit requires overcoming inertia.
Like, they know they should take folate, but finding the right brand, affording it, remembering to take it, it just feels overwhelming.
Exactly. So the clinician's job isn't to just lecture them about biology. It's to lower that friction and move them to preparation, where they are actively seeking resources, like checking supplement prices at the pharmacy.
And from there, they move to action.
Yes, which means implementing the change for at least 6 months, like taking the pill daily.
And finally, maintenance, where it becomes an automatic habit. You have to tailor your clinical intervention to exactly where the patient is on that continuum.
And you also have to tailor it to their cultural reality.
Yes, cultural competence.
It is an absolute make or break factor in dietetics. Interventions fail if they ignore culture.
Give me an example of that failing.
Well, if you are counseling a Vietnamese Hmong mother and you hand her a standard USDA grain chart centered around whole wheat bread, you have lost her trust immediately.
Because she doesn't eat bread.
Exactly. Or if you are treating an older African-American man and you don't take the time to understand the specific components of his favorite Brunswick stew, your advice is just irrelevant to his lived experience.
But you know, I really want to push back on this because it comes up constantly in medical training.
Sure, go ahead.
As a medical professional, you are dealing with a packed waiting room, limited time, and serious pathology. Shouldn't our primary job just be to give the patient the cold, hard, physiological facts?
Just deliver the USDA guidelines and walk away.
Yeah. To say, here are the guidelines and here is the biochemistry of what will happen to your kidneys if you don't follow them. I mean, why is it our responsibility to hold the patient's hand and navigate their psychological stages of change and study their cultural recipes?
It is a totally valid frustration, and I hear it from young professionals all the time. But the clinical literature is definitive on this. Knowledge rarely equates to behavior change.
Really? Just knowing isn't enough?
Not at all. Human beings are not rational metabolic machines. If simply knowing the facts change behavior, no doctor would ever smoke a cigarette.
Fair point.
Learning is a developmental emotional process. If you take a prescriptive, authoritarian approach, like a magic bullet lecture, it almost guarantees noncompliance.
Because the patient feels judged.
They feel judged, they shut down, and the intervention fails completely.
So facts without empathy are practically useless.
Completely ineffective. This is why the Academy of Nutrition and Dietetics mandates the total diet approach.
Okay, what does that mean?
It focuses on variety, proportionality, and moderation. but it centers entirely on the patient's current stage of readiness and their cultural identity.
So if your diet plan demands they abandon their cultural foods, they will simply abandon the diet plan.
Exactly. The true art of dietetics is translating complex biochemistry into a language and a lifestyle the patient can actually sustain.
Wow. You have to speak their language to get the biological hardware to actually upgrade. That is incredibly profound.
It really is.
All right, well, we have covered a massive amount of ground today for you all.
We really did.
We started at the microscopic level, unpacking the precise fuel factors of our macronutrients, and exploring how the fragile software of vitamins acts as coenzymes, while the indestructible hardware of minerals relies entirely on the complexities of bioavailability in the gut.
Right, the spinach and oxalic acid example.
Exactly. We then traveled along the life continuum, seeing how maternal feeding physically passes down an epigenetic heritage.
And how the mechanical stress of resistance training paired with leucine can activate that MTOR pathway to reverse muscle loss in our 90s.
From there, we stepped onto the clinical floor, breaking down the nutrition care process. And we recognized that psychological Hawthorne effect when choosing between a 24-hour food recall and a food diary.
Yes.
Finally, we zoomed out to public health, recognizing that all our biochemical knowledge means absolutely nothing without economic infrastructure, cultural competence, and an understanding of a patient's psychological stage of change.
It is a framework that proves nutrition is never just one thing. It is molecular biology, clinical pathology, and human psychology all happening simultaneously.
And as always, we want to make sure you, the listener, can apply this on the floor. So based on today's deep dive, here is your clinical review exercise.
Listen closely.
Imagine you are assessing a frail 85-year-old patient who has lost significant muscle mass. Which specific dietary assessment tool would you use to evaluate their daily protein intake? And how would you explain the difference between their static medical diagnosis and the dynamic nutrition diagnosis you formulate?
How you answer those questions changes the entire trajectory of their care.
It is the difference between just charting a disease and actually healing a patient.
And, to leave you with one final provocative thought to explore on your own,
Let's do.
the text briefly mentions a field that is currently exploding in the literature called nutrigenomics.
Nutrigenomics, okay.
It is the study of how the exact chemical composition of the food we eat physically interacts with our genome. Certain nutrients act as molecular switches, literally turning specific genes on or off.
Wait, real?
Yes, which begs this massive question. If the exact chemical composition of the food we eat can turn specific genes on or off today, how might the seemingly mundane dietary choices you're making right now be physically programming the health, development, and disease risk of your future unborn grandchildren?
Wow. The structural X-ray really is completely inadequate. The picture is so much deeper and so much more dynamic than we ever realized.
It's all connected.
Thank you all for joining us on this deep dive. We'll catch you next time.
Keep questioning the assumptions.
Always. Goodbye.
Goodbye.